Respected Dr. Soma Sundaran sir, Dr. Gerard, dignitaries, experts, friends and colleagues. It's always difficult to present a topic in the afternoon, and better to have one screen at the mess hall also. This will increase participation by 3 times. So thank you for being here in the hall. So my presentation is on evidence-based protocol. So you guys might be working in hospitals, PHCs, health and wellness centers. So NCD is not a independent vertical. So it will influence all the health workers. Can we go to the next slide? So Dr. Gerard in pre-learn session has given a pretext regarding what is the burden of NCD. So like we are in country like India, sometimes back it was 63% of the death due to NCD, but some data suggests that now NCD is responsible for almost 70% of the death. If you look at the first sustainable development goal, 3.4, which is directly related to NCDs, so that says that by 2030, we have to reduce premature mortality by 1/3 through prevention and treatment, and mental health and well-being is part of that. So a small question to audience, what do you feel whether we will be able to achieve this SDG target or not? Yes or no? Any answer? So most probably we may not be able to achieve this target. So there are some reasons, we'll be discussing that also. So there are certain other global action plan targets which are mentioned and which has been accepted by many countries. One of them is 25% relative reduction in risk of premature mortality. 80% of the individuals in public and private facilities should have access to affordable technology and medicine. WHO also promotes protocol-based treatment. We also encourage member states and countries to adopt drug therapy, which will help in treatment control and maintenance of patient on treatment. Next slide. So I happen to go through this document. Most of you might be aware of this document. This is the Tamil Nadu State Health Policy, and which has endorsed the global target and the SDG goal, which were customized for India. And this document clearly emphasizes on basic components and the topic which I am presenting here, that is early detection and treatment of NCDs, as well as regular follow-up and improving control rate. Next slide. So we were discussing about SDG, and whether we'll be achieving or not. But if you look at our country, when we look at the prevalence and the control rate, so globally we can say the control rate in the NCD programs is almost around 50%. But India, we are barely touching 17%. So although we have been enmassing so many patients, but the control rate or the control of patient basic parameters is not achieved. So all these patients, like almost 83% of the patients, are exposed to complications like stroke, STEMI, kidney diseases, and that's how we are not contributing to prevention of deaths among NCD. Next. So what is the mean age of premature death in India because of ischemic heart disease? Can you push the tab? Yeah. Next. Yeah. So 55.6 years. So this is much lesser than the global target. So in India, NCDs, ischemic heart disease, complications of hypertension and diabetes, they arrive early. So definitely we need to intervene as early as possible. Next slide. So how to address this particular issue regarding treatment, management, to be very specific, sticking to the treatment protocol. So WHO has developed technical package which has major components which includes, next. So these are the major components, HEARTS package, which includes healthy lifestyle counseling. The most one which we are discussing right now is evidence-based treatment protocol. Also, it is important to have access to medicine and technology. Then risk-based management of, for CVD. Then engaging all staff in care and management of hypertension, diabetes complication, that is treatment-based care. And we were discussing about the digital technology. So it is very important to have a system of monitoring, and digital technology helps a lot in developing those system of monitoring. So why, coming back to the topic, why we should have evidence-based protocol? So whenever, when we think of evidence-based protocol, so protocols are, they are based on certain evidence generated over a period of time. So it helps in standardization of treatment. So all patients get similar treatment, whether it is in village, rural or private or urban areas. It also helps in improving the patient outcome. Since the protocols are simplified, it can be implemented at the lowest healthcare facilities. Equity is also taken care of, whether it is rural, urban or tribal areas. All the patient gets a similar quality of care. So the issues of under treatment or over treatment can be avoided. Since we have limited numbers of drug patients, parameters are standardized. It also helps in monitoring and accountability of the system. And when we compare with the more than 250 drugs which are there for treatment, and what we have in a protocol are just limited numbers of drug. So this also helps in cost saving, cost effectiveness, reduce the cost of treatment among patients. So usually in a public domain, we usually have a guidelines, and we also have a standard protocol. So sometimes in a public health system, what happens, these guidelines are distributed even to the peripheral health system. But there is a clear demarcation between what is a guideline and a standard protocol. So guidelines summarizes all the recommendation. It is a comprehensive document. It helps in clinical judgment. It is used by policy makers as well as specialists to frame policies as well as to frame the protocol. So example is World Hypertension, WHO hypertension guidelines, which has been used for states and other countries to formulate their protocol. While protocol are step-by-step instruction, they are very specific, standardized, based on evidence which can be used at the PHC level. They are well formulated, rigid, so uniformity is maintained in using those protocols. So examples are WHO hypertension management protocol, heart strategy, and the protocols which we use in our state. So these are some of the examples of standard treatment protocol. So this is how guidelines and standard protocol differs. And in framing those guidelines and protocols, usually all these documents are used. I'm not going into details of that. So there are certain guidelines such as JNC7, American Heart Association guidelines. These are used as a reference for development of protocol. There are many studies which have supported standardized hypertension and diabetes protocol, that how it has improved the system of management, patient care and management. So in India also, India Hypertension Control Initiative project was implemented in 2018, and the standard treatment protocol was the first time it was introduced in India, and this has shown great results. It has helped in improvement of patient treatment, quality of care, then management of drugs, supply chain management of drugs. And in a long run, it has helped system in improving the care and management of hypertension and treatment. And simultaneously, these protocols have been also adopted in the national program. How WHO is supporting? So WHO supports in facilitates in development of this protocol, working in conjunction with the states. WHO staff also helps in capacity building. They also help in guidance on drug forecasting and manager. Like in Tamil Nadu, we have Dr. Gopinath and Dr. Emmanuel. They are part of the WHO team. They supports the state NCD cell in improving the quality of care of NCD program implementation. So in India, currently, majority of the states have adopted hypertension and treatment protocol. This protocol, which we started developing way back since 2018, so they have all the new evidence, but over a period of time, there are certain new evidence which have been generated by studies and various things. So most of the states like Jammu, Kashmir, Assam, Telangana, West Bengal, they have modified that protocol, and will be going shortly through what are these evidences which we can include in the protocol. So this is the Tamil Nadu hypertension protocol. If you see, it has most of the element or most of the evidence included in the protocol. Example, we use drugs like CCB, ARBs and diuretics, which have been recommended by many evidences. They are safer drug, they have a good bioavailability, they can use once in a day. Apart from that, we have a cutoff guideline of 140/90. So that has also helped in standardization of the control rate, or how we can monitor the patient continuation. So some of the protocols, some of the evidence are already there in the protocol. We'll see what are the new evidence which can be included. Similarly, if you look at the diabetes protocol, many of the evidences like what is the cutoff point, drugs to be included, are part of the protocol. So what are the new recommendations which we can include in the protocol? To begin with, so there are new evidence which suggests that inclusion of statin can prevent mortality in long term. So, and use of statin doesn't require monitoring of cholesterol over a period of time. So some of the suggestions are for hypertension, like patient with hypertension and diabetes should be started on statin as early as possible. Patient who are smokers with hypertension and above 50 years, should be provided with statin. For diabetes, all patients above 40 years should be given statin. So there are evidences which suggest that in India, infectious ischemic heart disease, they arrive early. So it's better to treat such patient with statin. Statins are safer. Studies have shown that the side effects are less compared to what was evident. So definitely it has a benefit in reducing the mortality by almost 15%. So although there are certain risks associated, but when we compare in a programmatic setting, the risks due to statins are less. Then this is how statin can be included. Like we can include statin along with amlodipine, since majority of the patient may require statin on a longer run. So protocol modification can be taken up by states like Tamil Nadu to include statin. So other recommendations are like in diabetes, this is the world global diabetes strategy which has been adopted so that majority of the patients should receive correct treatment. And it has been seen that the diabetes control is less than 23%, statin use is lesser than that. But when we look at the newer guidelines, like drugs like SGLT2 can be also included in the protocol. So this SGLT2, like drugs like dapagliflozin, can replace glimepiride. And the evidence what we have is drugs like SGLT2, example dapagliflozin or semaglutide, they help in reducing heart failure, mortality due to cardiovascular incidences. They have a protective effect on kidney, weight loss, and also has shown that reduction of mortality is beneficial when we use SGLT2 and GLP drugs. Right now we use metformin and glimepiride. So glimepiride can be replaced by SGLT2 and GLP-1 drugs. So this is a Kepler-Mayer curve which shows that the survival rate by using SGLT2 is better than sulfonylureas like glimepiride. So definitely this is a huge recommendation why SGLT2 can be used. The third recommendation is fixed drug combinations. Like we usually have generic drug in our system, but if fixed drug combination or combinations of 2 or 3 medicines is available in the system, it simplifies the regime, it reduces side effects, it reduces the number of episodes when patients are having treatment or taking the treatment, and it also will reduce the cost over a long run. So fixed drug combinations are the third recommendations for the treatment protocol. If you look at the newer updates like WHO Essential Medicine list have included SGLT2, GLP drugs, as well as previously in 2023 thiazide groups were also included in the WHO Essential Drug list. If you look at the Tamil Nadu EDL list, we have almost majority of the drugs. Rovastatin 5 milligram tablets are not there, but FDCs are not yet part of the EDL list, which we if recommended, I think that would be a good addition if FDC was supposed to be included in the protocol. So suggested approaches based on the newer evidence, inclusion of statin for hypertension and diabetes protocol. For diabetes, inclusion of SGLT2 and GLP-1 drugs can be included in the protocol. Definitely fixed drug combination is the another area where we may have to work. And all these drugs, if they are included in the EDL, definitely they can be part of the protocol. So it's very important that to build a resilient health system which is not affected by ups and downs, it's very important to have a standardized treatment protocol. Apart from standardized treatment protocol, it is very important to have systems, digital health system which tracks patient registration, patient control. Control rate can be a good addition to the MTM software, which will help us to understand how many patients are taking treatment from government, how many of them are controlled, how many are taking from private, and what is the control rate among them. And the other aspects can be inclusion like multi-sectoral action plan. This is another area where this will help in expanding the coverage of the treatment as well as our control over how many patients are taking treatment. Out of that, how many are under control, and in the long run will reduce the mortality among hypertension and diabetes. So thank you. I'm Dr. Amol. I'm National Professional Officer, and I'll be happy to answer any queries if you have. Sorry, I have to run through the slide because of the time limit. If any queries, you can please share with us.
Thank you, Amol sir. I know Amol for the past 2 years. He is a very hard working person, right? We should adopt your advice.
Yeah.
நம்ம பார்த்தோன்னா ப்ரோட்டோக்கால் கைட்லைன்ஸ் சொன்னார் இல்லையா, ப்ரோட்டோக்கால் வேறு, கைட்லைன்ஸ் வேறு, ஜிஓ வேறு, டெய்லி நம்மளா ஒரு ஓன் கைட்லைன்ஸ், சம்படிஸ் ப்ரொடியூஸ் ஓன் கைட்லைன்ஸ் வேறு. ஸோ வி ஆர் ஆல்ரெடி put on some 2 protocol.
Yeah.
We will think convene next meeting. So statin 40 milligram available in Tamil Nadu, but 10 milligram 5 milligram not available. So statin 40 milligram may be added into the hypertensive patients group. We will take in that. And next one drug is not in EL list, right?
Right.
We are write a letter. We are planned to write a letter to TNMSC we will get into touch with. Thank you.
Thank you for extending that support. We'll work on this thing. Thank you. Yeah.